Well, welcome everyone. My name is Amber Weisseth. I'm the Director of the Delivery Decisions Initiative at Ariadne Labs and have this amazing privilege to partner with PQC as well as all of you guys here on the call, which will go through all of the hospitals in just a minute. But this is our really kickoff webinar. So we're gonna give you an overview of what to expect in the project, as well as talk about really some details that you know for what's the immediate next steps. So before we get into all that, I want to go over an agenda slide so you can see what we're going to cover. All right, so we're going to do some hospital introductions. Again, an overview of TeamBirth, which if you were on the last webinar we had, we went into it at greater depth, but we will still revisit it today just at a high level to remind you what the components are that we'll ask you to implement. And then we'll talk about what those implementation steps look like and really forecast over the next kind of 6 to 9 months, you know, a little bit dependent on COVID, but we'll at least forecast what's coming up. And then we'll go over any questions you guys might have and talk about next steps. All right, so we're going to start with just showing you a slide of the delivery decisions team. So this is our team that makes up the Delivery Decisions Initiative at Ariadne Labs. Many of these people are behind the work of TeamBirth, and you will meet them at parts during the project. So on the call today is myself, Tricia Short, who's our implementation specialist, Avery Plow, who's our design lead, and then Yara is our one of our research assistants, and so she'll be presenting some content as well. There may be other team members who joined, but those will be the main folks you'll interact with. So again, we're going to focus on what is TeamBirth for a couple minutes. Tricia Short is our implementation specialist at Ariadne Labs, and she's going to walk us through very high level what the components of TeamBirth are, so that when you really think about how you can implement this within your system and your context, you again have that reminder of what are we actually talking about here with TeamBirth. So I'm going to hand it over to Tricia. Go ahead.
Great. Thank you so much, Amber. So I know at our last webinar, we gave a really high level overview. I'm going to go into a little bit more detail of the components of TeamBirth, starting with the huddles. So TeamBirth is a care process innovation, and it's based around regular team huddles that involve the full care team. So this includes the person that is in labor, so the patient, if they have a support person, and then all of the team members. So whether that is at your facility, your nurse, your midwife, your resident, your provider, it's bringing those team members together to really discuss about where you are in the labor process, what your goals are, if there's any concerns, and what your interventions might be. So really bringing the team together. What we like to think about is taking that conversation that we have historically had at the nurse's station and bringing it to the patient's bedside to elevate the level of transparency, but as well as the engagement of the patient, so that they really understand every single aspect of the care that they are receiving, and that they have a voice and an opportunity to engage and also ask questions. Amber, if you could advance to the next slide. So let's kind of dive into that a little bit more, thinking about when the team will come together, who will be there, when they need to come, what are the reasons, and what will be discussed, and why. So who is the full direct care team? That always will include the patient in labor. What you will be discussing is the whiteboard that we will have anchored on the wall, which we will go over more in detail here in a moment, is just reliably going over all of the aspects of that patient. So her preferences, what she hopes to occur during her birth experience, what her goals are for care, as well as what the medical team's goals are for mom, baby, and progress. And then when the team expects to come back together so that the patient can get another check-in or a huddle to discuss, you know, where you were, what you did, and where we've come, and what we need to do to continue to move forward. When we come together, I do want you to hear it's not going to be an abnormal request. It's not going to be any additional requests. It's very similar to the times that you would already come together as a team. So of course, at admission, anytime there's key decision points or changes in the plan of care. So if there are concerns or interventions that need to be taken care of, when the nurse would typically call a provider to give an update, those would be still the key components and opportunities to experience a huddle, but rather than having it at the nurse's station, pivoting it to the patient's bedside or at the request of any team member. So if a patient has a concern or question or their team member and they request a huddle, that's an opportunity as well. And then why we do this is we're giving all team members the opportunity to participate in shared decision making. So there's transparency at all times, at all levels, to the patient's desire and engagement, and they can participate to the full capacity. Amber, if you wouldn't mind advancing to the next slide. So this is a simple layout of the shared planning board. So the goal is that the team will come together in a huddle, identify the patient, their support person, and the team that will be caring for them. And we recognize this may change with shift changes or with residents swap out, or even providers going on and off call. But who your team is at that moment, what the patient's preferences are, recognizing that they may change throughout her labor process. You know, oftentimes this is a simple explanation or example, but patients may come in and she may desire not to have an epidural and she wants to go natural and local. But, you know, when she progresses in labor, that preference for her may change and she may desire an epidural. So just meeting the patient's needs as they evolve through the labor process. And then the plan of care every time is reliably structuring conversation around how is mom doing? Because we know she's more than just a uterus and a cervix. How is she doing? What are her needs? How can we support her? And then baby, of course, how is baby tolerating labor? Are there interventions that have been done? Were they successful? Are there interventions that need to be done? And then labor progress, what we are doing to help this patient continue to labor successfully and hopefully towards that vaginal delivery. And then, of course, when we will come back together as a team to huddle. So this is really taking that structured communication, anchoring it on a whiteboard in a place where the patient can see it, in a size that they can read it from their bed. But really, it gives them the opportunity to digest what the team just informed and discussed, and then provide them with kind of even a timeline for their labor process and what the goals are. So I would love to take a moment to pause and just invite people to come off mute. We recognize that every hospital has different variations of maybe whiteboards or maybe none at all. So,
and then we'll want to work with your team on thinking about which components are really necessary to keep on the board. What we find that most hospitals do is they design a board and then they add too many components, and so that it becomes kind of busy and hard to actually utilize.
Yes.
So simplicity is one of our really foundational principles. So we'll work with each of the hospitals to really identify what's the most simple design we can go for that still achieves the aims as well as is consistent with any hospital regulations that you might have. So that's really helpful. And then how about for Hillcrest Bailey?
Okay, we actually just recently implemented new boards onto our unit, about 3 or 4 months ago. We're an LDRP unit, so our boards have information such as today's date, the preferred name of the patient, the support person's name, what their care team is, so the OB, the pediatrician, nurse, lactation secretary, unit secretary. And then for our laboring patients, we have their last exam, when they ruptured, was it clear fluid, when are they due for their next exam, what their pain rating is, when their next dose of pain medicine will be available. And then for after delivery, we have information about the baby. So the birth date, delivery time, birth weight, length, are they breast or bottle feeding? Do they want those medications such as the hepatitis B, vitamin K? If they're having a male, are they going to want a circumcision? And then for our lactation portion, we have like day 1, day 2, day 3, as far as wet and dirty diapers to help keep track of that in the 24-hour period. Excuse me, 24-hour period. And then we try to teach our mamas to try to get 8 feedings in that 24-hour first 24 hours. So we do the boxes, and that way they can just simply put an X in the box. So they have a visualization of how many feedings they have gotten in that day. And then we have just a miscellaneous box to put any other information that's needed.
Great, thanks, Angie. And a couple of the hospitals that we have implemented in have also been an LDRP model. So we can definitely share the learnings. And actually that's how TeamBirth ended up getting implemented in postpartum, is from our LDRP hospitals who used the board and then just kept using it because the patients really liked it. So it'll be fun to connect with you guys specifically about that.
We have the boards that have not exactly what yours shows, but essentially the same thing. I think the thing that we're not doing is sort of the discussion around it with the patient. You know, I think that gets introduced from the nurse's standpoint, and I'll change it if it happens to have a different OB hospitalist on that's caring for them, that it wasn't me, I'll change it. But really there's no huge discussion around it.
Yeah, no, that's perfect. And I'm glad that you picked up on that nuance, because that is one of the main things that's different with TeamBirth, is really having those conversations be, you know, a 3-person, or have it all take place in the room versus having a bunch of one-on-one conversations with a game of telephone.
I believe the size is about 3 by 4, and they're glass where you can erase or wipe it off. They have most of the information that a lot of the others have, as far as the physician's name and the nurse's name and the nursery nurse's name, what their labor progress is, the pain scale, their preferences, what's important to me.
Oh, great. So you guys are used to kind of asking the preferences, what's important to the patient already. That'll help when you go to implement that.
And then their family contact and the room number and the phone number, of course.
Okay. Thank you for adding in that you have whiteboards, but they're not always visible, which is a huge challenge, because if we want to make this information transparent to patients and allow them or encourage them to participate, we'll want to think with your team about where boards could be placed that they would be accessible to all of the rooms. So thanks for adding that in. Okay, Trisha, I think back to you. Appreciate everybody sharing.
Yes, thank you all so much. So I want to go over also the discussion and support guides. These are add-on additional tools. The admission discussion guide is a tool that is meant to be utilized primarily in OB triage. So when you have a patient that comes in for rule out labor, rule out rupture of membranes, they can have this tool patient facing to provide education of what to expect. And also it can be very helpful from the patient's perspective with discharge instructions, just to really kind of validate and affirm why the clinical team is making the recommendation that they are, specifically if it is, you know, maybe being discharged to home or being discharged somewhere close to the hospital, but not yet ready to be admitted to labor and delivery, and still have that flexibility to get up and walk and drink and eat, and then come back as things progress. This tool, so it lives in OB triage. On the back side of it, it has a labor support guide. And this is meant to really just provide the patient with ideas and recommendations of how they can individually support their needs. So if it's mom, perhaps it's comfort. What are things that she can do? Be up, mobile, moving, shower, hot bathtub, breathing techniques. If it's her pain management, for example, is beyond that, it does also provide a space for what the clinical team, how they may be able to intervene and assist the mom. So whether that be with pain medication, and then it goes down for mom, baby in progress, things that the patient can do for themselves versus things the clinical team might be able to provide to support them. So on the front, admission guide, on the back, labor support guide. This tool will live in OB triage. In both of these guides, the idea and goal would be for them to be introduced in the prenatal clinic setting. So the patient has some familiarity and understanding of expectations when they come into the hospital, into the OB triage area, what is going to happen, what to anticipate and expect. And so that is being implemented in some of our sites right now with great success in the prenatal clinic, the introduction of these tools. To pivot over to the assisted delivery discussion guide, this tool is meant to be utilized specifically in labor and delivery. It also has the labor support guide on the back side of it as well. It provides the ACOG minimum requirements for a cesarean section. So if it's time to intervene and have an operative delivery, this tool validates and affirms again that clinical decision or the clinical team's recommendation for that reason. This tool we have found anecdotally by introducing it in, at all of our pilot hospitals and the hospitals we're currently implementing at. It's best if introduced prior to that discussion needing to occur. So typically it's introduced at the beginning of a patient's, whether it be her induction or if she comes in spontaneous labor, it's at the beginning of her labor in the hospital. And then that way, whenever the team comes back to utilize it for an educational tool and a patient-facing tool, they have familiarity, understanding, and perhaps hopefully they've already reviewed it and they can, and it just empowers them to ask questions, to be engaged, to really understand why the clinical team is making the recommendation that they are. In the case of emergency C-sections, we've had great success with some of our clinicians utilizing this tool as a debrief tool in postpartum, going back over what occurred, what happened, why the clinical team, acted the way that they did as quickly as they did. And it just really allows that patient to really understand what occurred and own their birth process. Our hope is that this will help patients really understand what happened to them. So I'm sure many of you have heard perhaps stories about how why patients needed to have a C-section. And sometimes it's hard to really understand exactly what did transpire because their understanding is probably a bit different from the clinical events that transpired. The goal is that each patient can own their birth story. They really understand what happened. They have peace about it. And if they have any questions or concerns, they're able to ask their clinical team immediately in the moment. So that's the utilization of these tools. I would also like to pause again and just invite you to share how you feel these tools might be successful in incorporating into your practice. I'm curious if you already have a really streamlined admission discussion or admission process. I know in some of the sites we heard great feedback whenever they had nurse turnover and a little bit of a newer, greener staff. This tool was especially helpful for the patient as well as the clinical team from the nurse's perspective. So do you guys have any questions or any feedback? We would love to hear any information. And I might just start, does anybody else have any questions or reflections before we move forward about the discussion guides?
I have a quick question. This is Dr. O'Daniel with Mercy.
Yes.
I may have missed it. Is this something that you're providing to have a guide on hand for reference, or is this something that you're handing to the patient, or is this something that's up in the room? Like, what kind of access are you suggesting that we have for these guides?
No, that is a great question. Thank you, Dr. O'Daniel. And I don't think I made it very clear because there are actually multiple variations that sites have through implementation found to be the most successful. So some sites, it is meant to be patient facing. So it's meant to be a patient facing tool. So whether that means that you hand it out each time that it's applicable to the patient in OB triage that is there for rule out labor and they receive this tool, or if it's just a laminated version that you pull off the wall and you utilize when it's applicable, either way. But the idea is that this tool is at some point in the patient's hands to really kind of help them understand whether it be their care in OB triage or their care in labor and delivery and why you're recommending an operative delivery. It's meant to be for them to visualize, to see, and to utilize to just help sink in and educate and provide opportunity for questions.
Okay, gotcha. Thank you.
Yeah, no, thank you so much for coming off mute and asking. That's a great question. If nobody else has any other questions, or if you feel free to, oh, I see Rena put in a question. Is this a paper pamphlet? It can be. So many facilities will hand it out. They have a stack printed in OB triage and they take it with their triage information for the patients, again, that it's applicable to. Others utilize it as a laminated form that always lives in their rooms. So, that's going to be something how each hospital can adapt it to meet their needs. And with that, I'm going to go ahead and turn it back over to Amber.
Thanks, Tricia. Just to piggyback on Rena's question, it was one of our kind of ideals early in the design of this admission discussion guide that this could be a potential poster in your triage space. Because one thing that's really powerful about it is it's really helpful at the moment when that patient is there for a labor check, but it's also really helpful before then, where they may be in triage for a non-stress test, or maybe they think they've ruptured their fluids. And so to have it on the wall where everybody who comes into that space knows this is how you as a hospital care for your patients, this is your standard of care, it's sort of expectation setting. So if anybody in this first cohort wants to be the first person to print it in a poster, we'll have to figure out some prize for you, because we've always wanted to see it in a poster form. And we also really recommend that these get handed out in prenatal clinics. So that'll be a part of the implementation strategy that we'll talk to you guys about, because the sooner on patients are educated about this content, the more likely they'll be prepared to engage with it when they're in labor and be able to participate in those conversations. Okay, so this is just going to give you kind of a high level idea of what we're thinking about for the timeline. So here we are. I can't believe, I think tomorrow's September. Yeah, tomorrow's September. So here we are. We're focused on meeting with your teams, kicking off the project, and really the next month is for you all to build your implementation team. So several of you announced yourself or introduced yourselves as being kind of a project lead, and so that means your hospital has already had that conversation and you've been volunteered or voluntold, however it happened. We're glad you're here. And that's really the focus of this month of September. We know there's a lot of competing priorities with COVID, with staffing shortages, and you're pretty stretched. So over this next month, figure out who would be on your implementation team, who will be able to volunteer their time or be asked as a part of their role to work alongside you and on the project. As we get into later in the fall, we're going to work with you guys on co-designing your implementation strategy and board design. There are several principles that we know are true regardless of where we implement, where at the end of this year we'll be in 23 hospitals across the US. But there's also specific things that are unique to your context, or Hillcrest is a good example. They had a stipulation from their system that hourly rounding be put on their board. So that's something unique to Hillcrest, but not to every hospital. So we'll be working with you to kind of figure out what those things are. Later on, again, we'll be focusing on IRB reliance. So we're really hoping to partner with you guys in collecting survey data from your patients. And that will serve a couple purposes. One, we'd really like to demonstrate a measurable impact on your patients across the state of Oklahoma. It's an amazing opportunity for us to have this many hospitals implementing and for really to be able to tell the story of the impact it makes to patients. The second thing that you'll hear a lot about, and hopefully you'll have firsthand experience in, is that the data that's collected from the surveys is one of the most powerful ways to support your implementation. We get a lot of positive patient feedback quantitatively through their responses, but also many patients will write in extra comments. That can be shared back to your team, and all the sites that we've worked with, that is one of the probably most important parts, and the part that brings you the most joy as an implementer, like reading those patient stories, because all of us here who went into healthcare, we did it because we wanted to make a difference in patients' lives. And that's that direct moment where you get to know you made a difference for this person. So we do hope you're a part of that process. It's also something setting up the IRB can be done in the midst of COVID, because it shouldn't really engage any of the frontline staff. It really should be our team. Amani Bright is on this call. It'd be really her as well as our team interfacing with your compliance or your IRB department. So again, if you have questions about that, we're happy to talk more, but it would be ideal to start moving forward with that in the fall. Obviously, administering surveys will start as soon as we have the IRB clearance from both sides. So that's a little bit TBD at this point. And then later on in the winter and into the new year, we'll work with your teams on really developing a training plan. We'll train you so that your implementation teams know what TeamBirth is and how to do it. And then we'll support you with resources to go back and train your staff. These are ideal months. This is what we first set out really before this Delta wave, which has hit Oklahoma in a really significant way. So I left the months here so you could see the ideal timeline, but just know that we are really motivated to work with your teams and really accommodate what your teams need to be successful with the project. So just have that caveat in mind. Ideally, we'd formally launch TeamBirth sometime early in 2022. And we'll talk more about that as we get close to it, what a launch actually looks like. So I'm going to go to the next slide here. So this is what I said for September. This is what you're focused on this month, is really building out the implementation team. All those little check boxes are sort of our recommendations or our brainstorm for you to think through around whether you have these roles within your hospital, who it could be. And depending on your hospital size and your capability, you may have some of these people and you may not. Patient and family representatives or PFACs, some hospitals have them, some don't. So you'll need to look within your own system to kind of build out the team. If you have questions, please do ask us. And then we do recommend that as the project gets underway, that you do meet weekly, or some teams choose to meet twice a week as we get particularly close to launch. But just as you're thinking about time commitments and who you want to ask, this is just kind of a high level information to get you started. And again, we'll send this out afterwards, so you'll get it in slides. We'll also send you like a 1 to 2 page handout that has kind of the big idea, what to be working on this month. Okay, so I'm gonna hand it over to Yara, who will talk about the board adaptation process. Again, the board design has to be done kind of earlier in the project, because we'll need you to work with your hospital teams, and we'll need to have time for ordering and installation. So Yara will walk you through that so you have an idea of what to expect.
Thanks, Amber. So as Amber just mentioned, adopting the shared planning board is a key step in the prepare phase of implementation. And this process really aims to create a sense of ownership of the board across your team and to ensure that the board works well within your own local setting and workflows. You're not alone in this process, and it will be important to engage with multiple stakeholders during the board adaptation process. So we really recommend you engage with your facilities team on the location and installation process. So thinking about questions like where will the boards go in each room and how long it will take to get those boards installed. And as Amber mentioned earlier on, board size really matters. So we recommend having a board that is at least 2 by 3 feet to make sure you have enough space to record everything. We also recommend you engage with your marketing and communications team on designing and printing the board. So you will really want to make the board your own in ways that promote engagement and use across your unit, such as adding a logo. So thinking through questions like, what are the brand standards for your site or system? And lastly, we really recommend you engage with your community to have input into the board adaptation process, such as testing the board and making sure that it also works for your patients. So asking your patients questions like, what would be meaningful for you to see in your care? Next slide, please. So the board shown on the previous slide was a generic version, so you'll want to think about the ways in which you can customize it. The board on this slide highlights one example of a site, St. Francis, that has adapted the design, the format, and content of their shared planning board. And as you can see, St. Francis added their own branding and nature imagery to match their site color stream. And they also adapted the board to include the date and room number. So when designing local adaptations for the board, it's important to train your implementation team to embody design principles of both, as Amber again mentioned earlier, simplicity as well as teamwork, and thinking about what resources you need to customize it, as well as testing the board with your teams and patients before finalizing any adaptations that you make to make sure that it works well for everyone who's not only providing care, but receiving care as well. And of course, our team will be there to support you throughout the entire process. Next slide, please. So these are just example boards for Hillcrest. So the board on the left showcases the shared planning board that has been adapted in the labor and delivery unit. And the board on the right just shows adaptation of the shared planning board in the postpartum unit. And so ultimately, what to take from this slide is that the same principles apply when thinking about extending and adapting the shared planning board to postpartum as well.
Great. So Amber had done a really good job about outlining kind of our timeline for what to expect in the next several months. But we also want to share with you what the immediate expectations and your next steps will be once we conclude this call today. So in the short term, if you haven't done so already, we would like you to submit the hospital commitment letter. We need 1 letter per facility or system. And this letter includes signatures from your nursing leader, your provider leader, and then executive leadership at your hospital. Then we, as Amber had mentioned, would like for you to consider and determine your implementation team and to determine who is going to make that up. So that includes the leadership within your team, but other champions and other data collection people and anybody on that list that she had shared that you might want to consider as part of your implementation lead going forward. We want you to determine the number and needs of your whiteboards and consider board placement. We will have a future learning session that will focus even more on the boards, but want you to kind of consider some of those bigger picture items related to boards as we go forward. There is a hospital registration form or a survey that we're going to ask each one of you to complete. And so that is on your checklist as well. The questions on that survey give us a lot of hospital demographic information so that we can kind of get to know the makeup of your hospital, your model of care, your staffing ratio, and other things that might impact how we implement TeamBirth within your facility. We're going to ask you to sign up for ARIA, which is an online collaboration with Ariadne Labs, where you can join their community of practice. And on ARIA are located multiple tools and resources that you might find useful as you go to implement, including the discussion and support guides that were already mentioned earlier. The Ariadne team is going to be starting the IRB reliance process, but we encourage you to help facilitate that as much as you can. And that could just be putting them in contact with the right people at your facility so that that process can go smoothly. We do want to begin monthly learning sessions, which are going to be in the form of webinars, real similar to what we're doing today. And then following those with monthly coaching calls. So in the learning sessions, we do have an outline of content that is a specific component of TeamBirth that we are going to focus on each month. And then the coaching calls that will follow will be an opportunity for somebody from the Ariadne team and our OPQIC team to meet with members of your implementation team at your facility. And in those calls, we plan to help to maybe troubleshoot any issues you might be having and celebrate the successes that you're having as you go through and launch TeamBirth. So we will be sending a sign-up sheet for those coaching calls and an email that includes all of this information, the slides from today, your checklist for September, and all of the links that you're going to need to complete all of those action items.
Denise, I can answer the question Rena posted in the chat around the board costs as you're starting to think about what your needs might be as an individual hospital. So it's part of why we were asking you guys which type of boards you currently have. If you have a glass board or a plexiglass with an insert that's a large board and it's installed in a good place, that's a easiest situation for your hospital. Really, all that we'll do is work with you on designing a new insert, and printing those out is $10, $12, pretty inexpensive per room. If you currently have a dry erase board and you want to convert to that model, that's the glass model with the insert, that's going to cost, most of our sites spend around $200 to $250 per room on those. So definitely more of an expense. There are some funds available to support if your hospital has a need in order to participate. So if you have a concern around being able to afford boards as a hospital expense, you will want to reach out to Barbara and her team at the PQC. But it sounds like most of you have the glass kind where you'd just be looking at a new insert. The other thing to mention is that we will be setting up another call later on this month with a few of our physicians who have doing TeamBirth in their daily lives, and one of them was in our original pilot trial, so she's been championing TeamBirth for the past, gosh, I think it's been 3 years now, as well as Dr. Irvin from Hillcrest joined us last time, and there's other physicians. So if you have docs that have questions, or you just want to hear from a physician's perspective, know that we'll send out information on when the next call will be scheduled. We've done a couple of them already, and they've been really helpful as the feedback we've gotten. So we'll do one later on in the month of September, and we'll be sure to send out that invite so you've got access to it. I think that was our, aha, that's right. Denise, did you want to do this one as well, or shall I?
Sure. So as I mentioned, we are going to ask each hospital or system to complete an information survey. So there's a link to it right here. If somebody wants to drop the link into the chat, feel free. It will also be included in the email that you are going to receive probably tomorrow as a follow-up to these calls. And then if you want to go ahead and shoot the QR code to start filling that out, feel free to do that as well. We only need one survey completed either per hospital. That way you might need to communicate amongst your team who is going to be completing this survey.
Thanks, Denise. And we really do appreciate you guys doing this. It really helps inform our implementation strategies and how we help your sites to implement. It will be different in a community hospital versus an academic center, whether you have residents, how many staff you have. So there are some things that we have learned along the way that we can really help set your team up to be most successful with your implementation. So really do appreciate you guys completing this survey. This is a snapshot of ARIA, which Denise mentioned signing up for. Now, it is optional. It's not mandatory. We're not going to enforce that you sign up for it, but it is a useful resource. You can see the web address down at the bottom. It's on the Ariadne website. And there's no fee for you. If you sign up, you'll get access to the tools, the resources. There's additional video content. There's our implementation guide. So it's a really helpful place to go. There's also a community forum where you can communicate with other folks that are implementing. If you sign up with your hospital email, we will be able to give you the full access. If you sign up with like a personal Gmail, we won't know it's you versus some random other person out in the world. So please do reach out and let us know so that we can give you the full access, which is a part of this project with Oklahoma. But do encourage you to do it. Hopefully you'll have some helpful resources there. So what we found most helpful last week when we were meeting with the hospitals is really to go through a couple of questions that you guys might have as teams. I guarantee you, if you are wondering about it or thinking or worried about it, somebody else on this call is as well. So would really love for you to be brave and speak up. We'll definitely just go down the list, and I'm just calling on you because I think that's easier than having to be the person to break the silence. So there's a couple strategies that we would recommend. One is if you have providers that are like leaders in your hospital or have a little bit more influence, would really recommend that they try to make it to the call that we have, the next one that we schedule. And if there's more need for this, we'll schedule more calls, because it is, I think, especially helpful for providers to hear from another physician as to how TeamBirth impacted their life. The thing that most providers are concerned about is whether or not TeamBirth will take more time. And so, you know, they're thinking they've got a busy clinic, they've got a lot of pressures on their plate. How are they going to make time for TeamBirth? So I want to at least reassure you a couple principles. One, we're not requiring you to huddle every 1 hour, 2 hours. There's no time restrictions. Your teams should be huddling at the decision points and at normal times where the team is coming together. So you're already the providers are already checking on patients. You're already calling them to admit the patient. We just want you to change your behavior. And instead of doing those as singular conversations, we want them to be all together. But there's no like frequency demand that we require. The other thing is what when we've implemented this historically, providers are always nervous. It's going to take too much time. But pretty uniformly across all of our sites, the feedback we get after 3 or 4 months of implementation is that it actually saves providers time. Because if they spend, 30 more seconds going over a clear plan of what's going to take place over the next 3 to 4 hours, it significantly reduces the phone calls an hour later around, when am I supposed to start the Pitocin ad, or when are you coming back to check the patient? Because it's all very laid out and it's on the shared planning board. So most providers do feel that after we've been doing TeamBirth for a couple months, that it reduces the amount of unnecessary calls they get. St. Francis also implemented a unique huddle called a tuck-in huddle. Not all of our hospitals have used it, but Tricia, why don't you just mention it? Because I think that was really impactful to your physicians' kind of quality of life.
Yes, absolutely. So this was a tuck-in specifically for, it started with cervical ripening patients that were admitted in the evening. And so what would happen is the nurse would call the patient or call the physician from the patient's room. They would utilize the speakerphone function on the nurse phone to do a huddle, and they would just discuss the goals and the plan for the night. So for example, if it was a side attack induction and at 2 a.m. when the patient was anticipated to get her second dose of side attack, if she was contracting too much, what's the plan? So oftentimes the providers already have an idea in mind of what they want for that particular patient. And so they could provide them with either, I want you to call me and let's discuss it, or I want you to give her a fluid bolus, wait an hour, and then if you are still unable to give the side attack, go ahead and start low dose Pitocin. So this actually eliminated many phone calls in the night for the providers, which they really appreciated. But it also provided the patients the opportunity to kind of let their family, especially during this time of COVID when their support systems are very limited in the hospital, to really provide kind of the plan and details of care for their family at home. So what we often found is patients would be calling the grandmas to let them know, you can go to sleep no matter what, we're not starting Pitocin until 6 a.m. So rest peacefully. I'll let you know if something changes. But the patients really, really appreciated it as well. It also eliminated patient, confusion or just misunderstanding when in the middle of the night things would change. They already had an idea of what was going to occur and then what the plan was going to be. So that was the tuck-in. We had great success with it. It can also be utilized in other various ways, but that's kind of how it started, and it evolved from there with the cervical ripening patients.
Thanks for sharing that, Tricia. You've also mentioned nurse buy-in. Historically, we've not had a significant challenge around nurse buy-in. When you really message what the project aims to do, really elevating the patient's voice and involving them in decision-making, that is a message that aligns with nursing care in many ways. Now, you'll probably have some nurses on your unit who are resistant to all change, which is just general change management strategies, but we'll work with your teams on what has worked most successfully. But nursing buy-in is typically a little bit easier than physician buy-in. Now, this is a different implementation environment, as all of your nurses have been working in a really extreme, difficult COVID environment for the past 18 months. So we do understand it may take longer to get buy-in, and it may look different than some of our other previous work. So totally understanding this is a little bit, there is an unknown factor here. I will tell you, we did launch with 4 new hospitals in between March and May, so kind of right in the midst of the pandemic. And one of the things that they feel it really is helping their team stay unified in this is TeamBirth, because not only are they aligned more as a care team, so there's less friction on their unit, but they're also really benefiting from the patient feedback. Patients are really noticing a difference, especially in your local community at Hillcrest and OSU, are really noticing a difference in experiencing TeamBirth and the change in the hospital care. And that is very powerful to motivate staff to stay engaged, that although they may feel like they're not able to do enough and they're always overworked and understaffed, that patients are really noticing when they're meeting their needs and really attending to them. So those are some of the strategies that we'll work with you on. And again, we'll have to think more creatively and more patiently around getting buy-in across the hospitals that are represented here today. I wanted to see if I can put Tori on the spot for a second. Tori, are you still on?
Yeah.
Okay, perfect. Don't worry, this is not hard. When you looked at that shared planning board and really those major 4 quadrants, do those align with pretty much what you intend or what you do for your normal practice when you see patients in labor?
Yeah, I don't think that the concept of the board is really where the difficult obstacle is going to be. I think, I'm not sure if you wanted this full long explanation, but I think that those are kind of what we're already doing anyway. As a hospitalist, I think I have a slightly different perspective than some of my colleagues who are trying to be in clinic or the OR or at home or what have you when these sort of practices are happening. So talking about being able to do this via speakerphone for a physician that's at home, I think is really ideal. And as long as their voice is being heard and it's not being recommended that they have to be physically present for these things, is really important just to help maintain some satisfaction from a physician level. For me as an OB hospitalist, it's not a huge deal if my shift is already in-house, and so to go up and have these conversations in person is really easy. I do have a quick question though about, is the anticipation that this happens at each shift change? So like when a new nurse comes on, is the anticipation that this happens again with the patient or no?
Yeah, that's a great question. So no, if there's a change in the plan of care or there is a decision being made with significance, then a huddle should be called. But if it's a nurse-to-nurse handoff, we highly recommend the board is used as a handoff tool, but you do not need to then call the provider just because you have a shift change. Does that make sense?
Okay. Yeah, so I think the board itself is, in our institution, is going to be a pretty easy implementation because I think that that's already happening. It's not happening in the formal way that you're suggesting, which I think will make the patient feel a lot more included. So
yeah, no, you're like a champion already. I don't know if somebody prepped you before the meeting, but you've got it. And I loved what you said, that these are the things you cover. And I would say, if you're a good provider, exactly, you should be covering these at minimum. The thing that catches people, or that they'll self-reflect after time, is like, I'm a good communicator most of the time, but not always at 2 a.m., not always every patient every time. And so TeamBirth helps me be more reliable. And so I really think that, like you said, it shouldn't be that different of a practice change, but it will be helping with reliability. It'll help with shared expectations, and it'll really help to engage the patient. So instead of just being a recipient of everything, they're actually going to have a voice and a role in their care that's different from before. So, and that's the thing that patients really articulate is really meaningful to them. So are there any concerns that you, or I know Chad is also on, I'm not sure if he's still on the call, have in particular around implementing at Mercy, or any concerns that you have around provider engagement? Anything else?
Not me personally. I think that it'll be pretty easy to implement with my team, because there are 4 main OB hospitalists, and then there are a few that do some locum shifts, sort of like Dr. Smith was referring to. So I think it's going to be pretty easy on our end. I think that it's going to require us to implement it as a small group and show the success from the small group to get anybody to buy in that are currently practicing as generalists. And I don't mean to say that they don't want to do it. I just think that their perspective is a little bit different with their schedule than ours is.
Mm-hmm. Yeah, no, I totally understand that. Our other hospitals that have had hospitalist programs really, really appreciate TeamBirth. for the reason that you're often the first person that's called if there's an emergency and the provider's not in house. Being able to look up at that board and first of all know who's in the room and to know what the plan had been gives you a lot of helpful clinical information right away for you to then know how to proceed in taking care of that patient. So it'll be interesting to hear from you kind of after you've been implementing it for a little while on if you think it helps you to actually work as a hospitalist in a more informed way, especially in those emergency situations.
Well, I think it would actually open up an opportunity to have the hospitalist who's on for the day also be listed on that board, because one of the things that happens as a hospitalist is a generalist is taking care of a patient, and myself as a hospital is not involved, but then an emergency arises and I get to them quicker than their physician gets to them, then it would be important for them to have at least heard my name and know that I exist and know that there is a physician that's in-house 24/7. And I would see that as a huge benefit.
Yeah, I agree. We really recommend that and have found that to be really successful. We've also found in hospitals that have done this, one hospital in particular has a really strong hospitalist program. It's actually the hospital that Dr. Chen worked at, which she'll be the physician on the call. They found that actually adding the hospitalist to the team made it easier for their providers to consult. They didn't have historically a culture where physicians consulted with each other on maybe difficult scenarios or labor progress questions. And they found that by having that hospitalist on as a named member of the team, it kind of opened that up to be a more natural conversation versus sort of a no-do thing. So again, that will be something that will be interesting to follow with your hospital as well as other hospitals that have a hospitalist program. So let me flip over. We talked to South and we talked to Mercy. What about Angie at Hillcrest, Bailey? Now I know you have probably talked with Evelyn as well as the Hillcrest team, so you have maybe a little bit more information around implementing in labor and delivery and postpartum, but are there any specific questions that come to mind or any concerns you have?
The only concern that I had after attending a couple of these meetings so far is we are a smaller unit. So like I said before, I'm an LDRP. I have 4 labor and delivery rooms, and then we can overflow into med surg if needed. I have 3 OBs right now, 2 primarily do a lot of deliveries there. And then I have 3 pediatricians. On most days, I'm going to staff 2 to 3 RNs, day shift or night shift. The only problems that I envision having to kind of think outside of the box about is huddles. So for example, in the mornings, let's say one of my providers has 2 laboring patients that day, and she has 2 moms from the day before that she delivered that she's going to make rounds on. So she's going to come deliver, go in and break water on both of her laboring patients, and then want to go make rounds on her 2 postpartum patients. And then a lot of times I have a pediatrician that I swear they leave their houses at the same time every time, they show up at the same time. And so she's going to come in and want to make rounds with those infants as well. And if I only have 2 to 3 nurses that day, I could see them being spread very thin as far as being able to make rounds with those providers.
That is a great question and definitely a more complex environment. We have implemented at a couple smaller hospitals, not actually fairly similar in size to yours. So we will definitely share those specific learnings as we work with you. But one of the things that comes to mind, especially with postpartum, because we haven't talked about that as much on this call, is when we implemented in postpartum, again, this was designed originally for labor and delivery, and because of patient demand and hospital demand, because patients felt really included, they had all this information, and then they went to postpartum or they just delivered, and then they felt kind of isolated. So our hospitals and our pilots started already experimenting with postpartum. We intentionally implemented in postpartum with these 4 hospitals in March and May. We were expecting it to be more difficult for some of the reasons you just named. Now you have 2 patients and usually the same nurse is covering them, and you're not just taking care of one room, you have multiple rooms, and in your case, you might have a labor patient. So what we found out, or at least to date, is that implementing in postpartum has actually been easier. And I think part of that is that you don't have as many huddles. So if things are going well, we're really looking at 1 huddle a day. So if there's, concerns or the patient is not stable, that will be very different. But for the average couplet, they're getting 1 huddle each a day. The other thing is it so improves the nurse's workflow that they are like dead set on being there for the huddle. I don't know if you've been a postpartum nurse, but if any of you have been, I have at times, you spend a lot of your time chasing around providers, trying to figure out what the order sets are and whether they've been discharged, whether they've written for medications. And if you can just be there for that 3-minute huddle, then you have your like marching orders, you know how to care for that patient throughout the day. So those postpartum nurses are very, very motivated to make it for a huddle. Some of the learnings we have from Hillcrest specifically is they match people up to have like a buddy system in the beginning of the shift. They cover each other for breaks. And then they also cover if a provider comes in to huddle on their patient and they're unavailable. So ideally when you have 2 to 3 nurses on, they would all kind of buddy and cover each other if one of them wasn't available to go in when the provider was there. But again, if those strategies don't work with you, we have some other thoughts and we'll work with your team specifically on the coaching calls on how to make it successful for you.
Okay.
So I wanted to also touch base with Jill. So Jill, I know you're representing the Integris system, so your perspective might be a little bit different, but we would love if you have any questions or any concerns or anything that's making you nervous, would love for you to mention it so we can touch base around that.
Thank you so much. I think, I have the privilege of hearing from our great leaders across our system. And I think it was a very interesting conversation to hear from them as we began to talk about this. Everyone agrees it's a wonderful program and we're all very excited about it. But the things that I've heard from others is exactly what we're a little worried about. You already are typically worried about buy-in. And for us, it's mostly from the provider end that we're concerned about it. But it's the current weight of implementing something new in this current environment when everything already feels so overwhelming.
Yeah.
So I think for us, it's about, it was really important to us to see the timeline and to understand what this looks like. And, Barbara has been a tremendous resource to us as we walk through this decision making in reassuring us too, that if we ever hit a roadblock and things get crazier, this is not something that it's set in stone. It can pause.
Yeah.
And so that's been really, really important for us. And we actually will have some providers that will participate in the next phone call because we feel like it's critical to make sure nursing doesn't carry this alone. And so I think we've heard that throughout, but those are just the greatest challenges that my leaders are communicating.
Yeah. No, I thank you for saying that, Jill, because I think everything you just mentioned is what every leader on this call is thinking about, including ourselves. We spend a lot of time talking with Barbara and her team around this topic because we ultimately believe in the mission, which is continuing to improve care. And we want, women and their families and their babies to be safer in Oklahoma. We want them to experience birth with dignity, want them to feel valued and believe that that is a worthy mission to continue to strive for. And yet we know that this implementation environment is so complex and so difficult. So we are not going anywhere. I mean, this is the 3-year partnership at minimum, although Barbara's been around since the very beginning of TeamBirth. So Barbara, I think this will be a couple decade long, ultimate partnership. But like you said, if you reach a roadblock and we've got to slow down or adjust the timeline, like that, we'll do that. We're still committed to you guys as hospitals and systems and believe in your commitment to make a better experience and a better outcome for your patients. So I'm not sure that that's exactly reassuring since we don't know what the future holds, but I can just promise you that nobody is going to hold you to an unrealistic timeline in order to check a box. Like that's not how we'll work with you.
Thank you so much.
Barbara, anything else you want to add before I see what Christy from OU is thinking?
No, I thanks Jill and everyone else for speaking up. I do want to go back to Rena real quick about the nurse buy-in and mention that I think the nurses really appreciate that that when there's a question and you are having a huddle, they're having that conversation with the patient, so the patient and the doctor can speak directly to each other instead of the nurse going back and forth between the provider and the patient. And I wanted to allow Sarah to speak real quickly that, I know that she and her team of other patients have thought about TeamBirth and how it would have impacted their experience. And one of the things with the transparency of the conversations among the care team, having that with the patient and how that would have been so impactful. Sarah, are you able to speak to that real quick? Thanks.
Sure. Yeah. Thanks, Barbara. Yeah, we've talked about this with our team. We have a small team of other patient partners that help inform our work at OPQIC. And all of us believe that if we had experienced TeamBirth during our labor and delivery, that we would have had a much different perspective about what went on during labor and delivery. Even if the outcomes had been the same, it would have been a much more positive experience because we would have had a lot more information. We would have been included in the communication. For instance, I still 5 years later have a lot of questions about the communication that may have taken place during my labor and delivery and what the nursing team was communicating to the physicians and what the physicians were communicating back to the nursing team. I don't know what those communications were, and so all I can do is assume. But if I had been included in those communications, if I had been included as part of the team, I wouldn't have these questions, and I would be a lot more at peace about what went on during labor and delivery and how the team was working to protect me and protect my baby during all of that. So yeah, we're really excited about that potential. And, even if the outcomes aren't the same, at least you would be included as part of, or are the same, at least you'd be included as part of the team. So thanks, Barbara.
Thank you, Sarah. And one other thing I wanted to bring up real quickly, we had I had somebody message me earlier about concern about privacy and the providers being surprised by, hey, I've got you on speaker, I'm in the room, and maybe they're not ready for that type of call. They're not in a position to take the call, or they need some time to think about something first. So, if you can plan that, hey, I'm going to go in and do the huddle, call me when you're ready for the huddle, things like that. Sometimes they can be planned. Of course, sometimes they can't. But it's not like you're going to be surprised all the time that, hey, we're ready to talk to you about something, and the provider may not be in a place to do that. So just wanted to mention that as well.
Thanks for saying that, Barbara. Wanted to switch over to Christy and Chelsea at OU. What else are you guys worried about or thinking about that hasn't been mentioned yet, or we haven't covered clearly enough? It can be a repeat topic.
This is Christy. I was just going to make a couple comments. So we have implemented postpartum rounds, is what we call it, but our nurses go around with our OB physicians, and we have attempted several times with our pediatric physicians, but it just seems a little bit trickier. So hopefully this will help. But yes, we had talked with Evelyn from Hillcrest a couple weeks ago just to see what they were doing specifically on their postpartum unit, and they were giving us some hints about that. So we're going to be probably doing that at the same time. But also I was just going to talk about the board in general. Years ago, the other company that came in that, had us do our communication boards and our hourly rounding and all of that, the board seemed just very surfacey, if you will. We throw our information up there on the board at the beginning of the shift, but then it's never really utilized then actively throughout the labor process. So I think that this will give it a little bit more depth. And hopefully people will use it to incorporate the patient, because we're also with our bedside handover, it's supposed to incorporate the patient, but sometimes I still feel like it's the nurses, talking to one another, and the patient's input isn't as valued or, asked for. So,
yeah. No, I think that's a really important kind of conceptual component of TeamBirth is, it's one thing to put a board on a wall. It's another thing to change behaviors and ultimately change culture, because you're absolutely correct that nurses have been used to giving report to each other. So then we ask them to do it at the bedside. So they're still giving report to each other. They're just doing it while a patient awkwardly watches. But we want to move to this greater level of communication where the patient is involved in it and that their expertise about themselves is honored and recognized. So we do find that the boards are used. I think the simplicity of them helps, where you're not like, it's not as rigid about what you write in there. So you can write what's very relevant that fits in the categories, as well as we really encourage you to have the patient or their support people write on the boards. It is a great thing when you have a friend or a dad that's in the room that doesn't really know what to be doing. Give them the pen, write on there, like what's important. What did you guys think was important for the stage of labor? What are some of your preferences? Write them up there. We just talked about the plan for mom is to rest. Would you write that on the board? Anything else that comes to mind that we should do for mom? And so you can involve other people to be writing on the board. It does not need to be a fully nurse activity. And some of our hospitals, nurses do most of the writing, but it's really interesting because it's kind of cultural. Other hospitals, like physicians, do a lot of the writing. And we had some physicians that carried around fanny packs of colored markers because they really were like going for it. Some of our hospitals' residents are like some of the best champions, and they're really good at getting up there and articulating. And they haven't been in practice long enough for their handwriting to totally deteriorate and be illegible. So they can be really good at writing on boards, but it can be anybody on the team. It does not have to be a nursing task. And I think that's one of the important parts about it being a shared board for the whole team to come together. We do have a design manuscript that just was published a couple months ago. We have 2 other papers that have been sent in. So like we've had edits to make, and then we've resubmitted them. So I'm really hopeful those will be published in the next couple months, which also might be of interest to your providers. But we also have some data to share. So whatever the questions are, just please send them our way so we can help you and help them to make a decision.
Perfect. Thank you.
Yeah, so I think that kind of brings us to time. I really appreciate you guys spending the past hour and a half with us. Some of these meetings will be a little shorter. We'll probably just do 60 minutes. Some of them you can expect will be a little longer when we really get into training you. So at some point later on in the year or early in the new year, we'll want to train your implementation teams on how to do TeamBirth. So as you're going around and telling your staff about it, you actually know what it means to do a huddle and how you interact. So that will be a little bit longer meetings, but some of the ones in the near future might be a little shorter. So we'll be sure and get that information out to you, as well as the recordings, the slide decks, and what to be focused on over this next month. We do have a design manuscript that just was published a couple months ago. We have 2 other papers that have been sent in. So like we've had edits to make, and then we've resubmitted them. So I'm really hopeful those will be published in the next couple months, which also might be of interest to your providers. But we also have some data to share. So whatever the questions are, just please send them our way so we can help you and help them to make a decision.
Perfect. Thank you.
Yeah, so I think that kind of brings us to time. I really appreciate you guys spending the past hour and a half with us. Some of these meetings will be a little shorter. We'll probably just do 60 minutes. Some of them you can expect will be a little longer when we really get into training you. So at some point later on in the year or early in the new year, we'll want to train your implementation teams on how to do TeamBirth. So as you're going around and telling your staff about it, you actually know what it means to do a huddle and how you interact. So that will be a little bit longer meetings, but some of the ones in the near future might be a little shorter. So we'll be sure and get that information out to you, as well as the recordings, the slide decks, and what to be focused on over this next month.